Good evening, all of you. It's so nice to meet you all virtually. Am I audible?
Yeah, ma'am.
Yes, yes.
Okay.
You're audible.
So I'll dive straight away into the topic. I will be talking about secondary dyslipidemia. So the objectives that I have for this presentation is, one is
Dr.
when to
Smitha, make
Yes.
it a full. Your slides would be in full screen mode.
how do I do that now? How do I do that?
Okay.
Do slideshow.
Okay, go ahead. Slideshow.
Is it full screen now?
No. Now it is there. Yes, it is there.
No. Okay.
Now it's okay.
Okay. So my objectives are, one is when to suspect secondary dyslipidemia, what are the causes of the same, and I'd like to also to discuss a case at the end to give some context to what we're doing. Now, what is important to know about secondary dyslipidemia is, how do we define them? Basically, if an underlying condition is causing or exacerbating a dyslipidemia, it is considered to be secondary. Strictly speaking, if you should treat that underlying condition, then the lipid profile of the patient should immediately improve without any further intervention. However, in practice, that doesn't happen, because many of these conditions are associated with obesity and so on, and what we call as polygenic inheritance, environmental influences, and so on. So this definition that the dyslipidemia improves completely on treating the underlying condition, that does not strictly work. What we should remember, however, is there is an underlying condition. Now, why? Why is it so important to do this? Why should we know that there is something underlying? For several reasons. One is, it may be an important health issue anyway to recognize. Of course, we would know that the patient has diabetes. We would know that the patient has CKD. But sometimes the underlying diagnosis may not be so clear. For example, maybe a patient comes with a routine impaired lipid profile. He has hypothyroidism, maybe something else. So the impaired lipid profile may in fact hide an underlying dangerous diagnosis. The second thing is, the comorbidity may actually alter your treatment decisions. Let me give you an example. If the patient has something like hypothyroidism, you just recognize the dyslipidemia, you start treating with statins without reminding yourself, in fact, that statins increase the hypothyroidism-induced myalgia. So treatment decisions can also be influenced. Another important thing to know is, when you start treating the patient, they don't respond. So then you think, okay, is it a refractory dyslipidemia? But in fact, that refractory dyslipidemia may be secondary to another cause. Something which immediately comes to mind is alcohol abuse. So this is why it's important to recognize causes of secondary dyslipidemia. Now, when do you suspect? So often I see my PG residents, they see a patient's lipid profile report, immediately they start treating with statins. But my question is, when do you ask yourself, when do you tell yourself that there might be something else going on? Well, in the following cases, you suspect another cause. If there is a new onset or a progressive dyslipidemia with no family history, if in a previously well-controlled patient, you notice a gradual worsening of parameters, or again, in a previously well-controlled patient, you notice that suddenly the lipid profile deteriorates. Or as I mentioned before, if the patient becomes or if the patient is refractory to therapy. In these situations, you tell yourself it's worth looking for another cause, looking for a cause other than the polygenic dyslipidemia, which we are also familiar with. And always remember this, just that there is a primary inherited dyslipidemia does not preclude the patient from developing a secondary one. Nothing stops a patient with a polygenic dyslipidemia to develop hypothyroidism or diabetes or another cause of secondary dyslipidemia. So always keep in mind that a secondary dyslipidemia can worsen the parameters, can alter the course of the disease, can in fact result in a sudden catastrophe, like let's say it could be a pancreatitis in case of hypertriglyceridemia. It could be, let's say, an acute coronary syndrome. So always keep in mind that a sudden worsening in a patient might be because of a secondary dyslipidemia. Now, look at this. It's very important in considering secondary dyslipidemia to remember the 4 Ds. This is a mnemonic I teach my residents. The first, of course, is diet. That's simple. Very importantly, the drugs that you yourself may be prescribing. Metabolic disorders, which we are familiar with, and other diseases. All 4 of these can contribute to secondary dyslipidemia. Let's talk a little bit about diet and dyslipidemia. This is something which the man on the street will tell you, but still, I felt it bears repeating. What in the diet increases or worsens the LDL cholesterol? Definitely increased saturated fats and increased trans fats. Now, what are these saturated fats? Saturated fats are what is present in red meat, what's present in certain high-fat dairy products. Trans fats are what you get by hydrogenating oils. Something I used to tell my patients is, generally, if the fat that you are using is solid at room temperature, it might not be a good idea to use it in excess because they tend to increase the LDL cholesterol. How about weight gain? Now, weight gain does increase the LDL cholesterol, but what you have to remember is that when the weight gain is associated with insulin resistance, it has a slightly different profile. In other words, it has increased triglycerides, decreased HDL, and your small dense LDL particles. Now, what in the diet, or what would increase the triglycerides? What would decrease the HDL? Obesity, of course. Smoking. No argument about smoking. And it is found that when more than 60% of the diet is carbohydrates, that tends to result in hypertriglyceridemia. About ethanol. Now, based on popular literature, I have many patients coming and telling me alcohol is good for you. It probably has a friendly effect, let's say, on the HDL cholesterol. But not so much, please remember, not so much on the triglycerides. So if you have a patient with increased triglycerides, always consider and always ask a leading question about ethanol abuse. How about the drugs that we give? It's important to know about this, and I'll tell you why in just a minute. Which drugs are detrimental to the lipid profile? Oral estrogen causes hypertriglyceridemia, though not estrogen patches. Bile acid resins, which you use to treat dyslipidemia, increase triglycerides. It's probably important to remember and to teach our students that beta blockers and thiazides tend to worsen the lipid profile. So if you are treating hypertension in a patient with an impaired lipid profile, you might not choose a thiazide, let's say, as your first choice. Could you give a beta blocker? Well, yes. Carvedilol is supposed to be slightly more lipid friendly than metoprolol, for example. Glucocorticoids, cyclosporin, like Dr. Ashish mentioned, are fairly detrimental, as are antipsychotics. But what I would like you to remember, friends, here is mainly beta blockers and thiazides, because generally the patients that we have a constellation of diabetes and hypertension, metabolic syndrome, and we tend to use beta blockers and thiazides fairly frequently. This is not to say that all antihypertensives are detrimental to the lipid profile. For example, alpha blockers are beneficial. Hormone replacement therapy, it's a combination hormone replacement therapy, could be okay. Drugs like valproate and growth hormone are also beneficial to the lipid profile. But keep in mind, especially bile acid resins, because we'll be discussing this a little bit later. So we talked about diet, we talked about drugs. Now, let's talk about diseases and metabolic conditions which specifically increase the LDL cholesterol, which are, in other words, secondary causes of increased LDL cholesterol. I'd like to emphasize hypothyroidism. Now, it's found that if the patient has an E2 homozygosity for type 3 lipoproteinemia, this will be unmasked It's quiet until the patient develops hypothyroidism, and then this becomes unmasked. Here, the patient typically has Palmer's xanthomas. So let's say you have a patient who has Palmer's xanthomas and maybe an impaired lipid profile. Immediately what you would check for is the signs and symptoms of hypothyroidism and do a TSH as well. If you saw a very thin-built individual, immediately probably you would not ask for a lipid profile. But on delving into the history, if you find they have an eating disorder, you might consider anorexia or bulimia, and you will find that bulimia, in fact, has a more detrimental effect on the lipid profile. Why am I talking about pregnancy here? Why am I talking about the fact that pregnancy increases LDL cholesterol when it's impossible to prescribe statins in pregnancy? The reason is this. If I have a patient with dyslipidemia initially, let's say a familial dyslipidemia, I would strongly advise them to bring their cholesterol under control before even conception, as pregnancy itself would worsen the lipid profile. Dr. Ashik talked about nephrotic syndrome. I'm not going to talk about that. But I would like you all to remember that if a patient complains, let's say, of pruritus, has planar xanthomas, that is xanthomas on the eyelids, and has an increase in bilirubin, primary biliary cirrhosis is very well known to cause a terribly impaired lipid profile. Again, friends, what I'd like to emphasize here is probably hypothyroidism, for which you should have an extremely high index of suspicion. What are the causes of increased triglycerides, the secondary cause of increased triglycerides? Diabetes, as we all know, CKD, like was discussed just a short while ago, nephrotic syndrome, but also rarer causes like Cushing's disease, like lipodystrophy, like HIV. Now, we've talked so much over the last 2 days about the various drugs, but for a second, I think it bears repeating about the durable effect of lifestyle modification. Now, what I tell all my patients is this. Lifestyle modification is a low cost, no side effect method of treatment. It's not just that it's beneficial, it's that the beneficial effect persists. And that is why any treatment of dyslipidemia must begin with this. Now, what are the effects of a good diet and exercise? Well, it has certain effects. The first thing, obviously, it decreases obesity. But interestingly, friends, I'd like you to note that even physical exercise, in the absence of calorie restriction, even when it doesn't result in weight loss, it does result in a decrease in the visceral fat, which ultimately adds up to the good health. It decreases insulin resistance. And once again, I'd like to say that the lipid profile associated with insulin resistance, high TGL, low HDL, small dense LDL, this is a highly atherogenic lipid profile and therefore predisposes to cardiovascular disease. So your diet and exercise increase the LDL size, they increase the HDL cholesterol, and they decrease the TGL. Isn't this beautiful? I mean, is there any reason that you would not start your prescription for dyslipidemia? Why would you not start it with diet and exercise? In fact, for hypertriglyceridemia specifically, diet and exercise are the keystone of therapy. Of course, you do use fibrates. You might use fish oil. But for pure hypertriglyceridemia, especially if the triglycerides are very high, bile acid resins are contraindicated. Now, keeping all this in mind, I would like to tell you that remember that the drugs and diet therapy you prescribe itself might be a secondary cause of the impaired lipid profile that you're seeing. What do I mean? Suppose I have a patient with high LDL cholesterol and I prescribe a very low-fat diet. Unfortunately, that decreases the HDL as well. And therefore, the recommendation goes that fat should not make up less than 25% of the diet. Suppose the patient has hypertriglyceridemia, and like I mentioned a second ago, I prescribe fish oil. That will worsen the LDL. Suppose the patient has diabetes and dyslipidemia, I prescribe a combination of fibrates and TZDs. that causes a lone fall in the HDL. So what I'm trying to say is things are not very simple. You might have to delve into the history, into the diet history. You might have to probe into the prescription to find out what exactly is causing the impairment in the lipid profile. Again, keep in mind, very low fat diet causes a fall in the HDL. Never forget, bile acid resins increase the triglycerides. In light of what we learned so far, let us discuss this case. So Mr. X is a 52-year-old male. He has a BMI of 32. His waist circumference is 42. He's a known case of type 2 diabetes. His HbA1c is 10. So it's fairly evident from the slide that he is not compliant with his diet. He is not compliant with his exercise. Maybe he's not that compliant with his drugs as well, because you note that his diabetes is pretty uncontrolled. He was started on statins. Unfortunately, they caused myalgia. So he was started on cholestyramine, bile acid resin. Next, what happens is he presents to casualty with abdominal discomfort and is found to have a sky high level of triglycerides, 2,240 milligram percent. What's going wrong? What have we done? What have we missed? So the increased triglycerides in this case are due to various things. It's due to the high saturated fat in his diet, due to the high trans fat in his diet, due to the high calorie diet itself, due to the high carbohydrate diet. It's also because of the increased blood glucose. It's difficult to control the triglycerides without controlling the blood glucose, as we all very well know. And it's due to the bile acid resins. So in this case, it's the diet, it's the disease, and it's the drugs. All these are causing the problem. How do we manage him? Well, first, we make him talk to his dietitian. We impress upon him the importance of cutting down on the fats, cutting down on the calories, cutting down on the carbohydrates. We stop the bile acid resins. We use insulin to control the blood glucose. And then we notice that, yes, the triglycerides tend to come under control. So in this sinister combination of these three factors, which resulted in hypertriglyceridemia and probably pancreatitis, it just required a little bit of tweaking of his diet and drug prescription to bring the triglycerides under control. It's not always this simple, but it is possible. Now, how would you approach? Remember what I said in the very beginning, you suspect a secondary dyslipidemia if there's a sudden deterioration, either acute or chronic, in a previously well-controlled patient, or if the patient has dyslipidemia refractory to treatment, or if he has a new onset dyslipidemia without any family history. Additionally, you suspect a secondary cause if the non-HDL cholesterol is more than 220 milligram percent. What would you do next? You would screen for metabolic syndrome and diabetes. You'd look for the waist circumference, you'd look for the blood pressure, you'd check the sugars. You will take a history and test the TSH. Please remember that subclinical hypothyroidism has been implicated in secondary dyslipidemia, but the results of treating that are not very clear. Some studies say that yes, treating subclinical hypothyroidism improves the lipid profile, some do not. It is perhaps important anyway to check a TSH before statin therapy. Now I do this because if a patient on high dose statins starts complaining of myalgia, I want to know beforehand that he's not a case of hypothyroidism and his TSH is in the normal range. Check the urine protein for nephrotic syndrome. Check RFT, obviously. Rule out very rare conditions like like primary biliary cirrhosis. However, in this slide, if I would have to emphasize one thing, I would say always rule out ethanol abuse for two reasons. One is the message seems to have stuck in our patients' brains that yes, alcohol is good for you, especially if you have cholesterol. Alcohol treats cholesterol. This is what they think. Never forget that ethanol overuse, let's say, causes hypertriglyceridemia. So always rule it out. Now, again, I'd like to reiterate what I said in the very beginning. that management of secondary dyslipidemias begins with management of the cause itself. This is necessary but not sufficient. If the patient has diabetes-associated dyslipidemia, apart from statins and niacin, it's found that metformin and pioglitazone also have a beneficial effect. Dr. Asha has talked about statins in CKD, doubtful role of ezetimibe, but it has been useful. I'm not sure I mentioned this before, but we get many references from patients who are treated with antipsychotics. Apart from weight gain itself, they have terribly disturbed lipid profiles. What works for them? Statins, omega-3 fatty acids, fibrates. Interestingly, SSRIs and anti-epileptic drugs like topiramate also seem to have a beneficial effect. Once more, apart from treating with statins or with fibrates, as the case may be, remember that management of secondary dyslipidemia hinges on management of the cause. In conclusion, I'd like you to remember that to treat dyslipidemia effectively, always recognize the secondary causes. Never forget that the mere fact that the patient has a primary dyslipidemia does not prevent him from getting a secondary exacerbating dyslipidemia as well. Always keep this in mind. Never forget to begin with lifestyle modification. It's not just enough to prescribe lifestyle modification. You have to be convinced, and you have to convince your patient to follow that prescription sincerely. Be aware that all your therapeutic measures, like a very low fat diet, like your bile acid resins, all of these can have their own adverse consequences. So thank you all.